All right, guys, welcome back to Underground Science. In this video, we'll be talking about nitrates. We'll talk about the different types of nitrates, its mechanism of action. We'll definitely talk about how nitric oxide leads to vasodilation and so forth. Okay, so let's go ahead and get started. First, before we start talking about nitrates, let's talk about how a blood vessel constricts. Okay, so we have to talk about the smooth muscle that lines the blood vessel first. Okay, so let's go ahead and talk about a few examples. So if we talk about certain triggers, right, certain things that bind the receptors on the smooth muscle and how that leads to contraction and vasoconstriction of the blood vessel. All right, so let's say this is our receptor on the cell surface, okay, and what things can bind to this receptor? Well, what things lead to vasoconstriction, right? So right away, we can think about adrenaline, right? So epinephrine can definitely lead to vasoconstriction, right? Norepinephrine can lead to vasoconstriction. And then things like endothelin, right? Things like vasopressin or ADH. And what about angiotensin, right? Remember angiotensin 2? Angiotensin 2 can definitely lead to vasoconstriction and so forth. So we have endothelin, right? Specifically endothelin 1. So let's just squeeze that here. Vasopressin or ADH, and angiotensin 2, epinephrine, norepinephrine, right? All of these things can bind on the cell surface of a smooth muscle cell, and that will actually lead to the GQ pathway. Remember, so we have the G stimulatory pathway that we're familiar with that leads to cyclic AMP production and protein kinase A production. But then remember, we also have the GQ pathway, which leads to an increase in intracellular calcium levels. Okay, so it's going to stimulate the GQ pathway, right? So let's go ahead and write that. So it's going to stimulate the GQ pathway. And if we remember, when the GQ when the GQ is stimulated, right, the GQ protein, then that's going to eventually lead to the stimulation of phospholipase C, right? And then we know that phospholipase C is going to help break down PIP2 into two different molecules, one being DAG and the other being IP3, right? And we know that IP3 can then go to your sarcoplasmic reticulum and say, hey, release calcium into the cytosol. So it's going to release a ton of calcium, right, into the cytosol. And this calcium will actually then go bind a protein called calmodulin. Okay, so now you're going to have calmodulin and calcium together, which is called it's a complex. It's called the calcium calmodulin complex. All right. So now we have the calcium calmodulin complex, which is really important because this is what is going to lead to the activation of the myosin light chain kinase. Okay. So this will go ahead. So this is still inside the smooth muscle cell. Okay. This will activate myosin light chain kinase. Now, remember, we know that kinases are enzymes that phosphorylate certain things, right? So myosin light chain kinase is going to phosphorylate myosin light chain, right? So now we're going to have a myosin light chain with the and then that myosin light chain is going to be phosphorylated. So we have a phosphate group right there, right? And now this, right, myosin light chain that's now phosphorylated is activated. Okay, now this means that this myosin then can go bind to actin and then lead to vasoconstriction. Okay, so that's when the blood vessel diameter gets smaller. So that's how vasoconstriction normally occurs on blood vessels, right? With these being the triggers. So now that we know that biochemical pathway, that's going to help us a lot in terms of talking about nitrates and nitric oxide. Okay, so in fact, now that we know that, let's go talk about nitric oxide. All right. So nitric oxide production and its target. So how does nitric oxide get produced? Right. Let's talk about that. So in our endothelial cell, right? So we're not on our smooth muscle cell yet. Let's draw a big endothelial cell. Let's go ahead and label this endothelial cell. Okay. What is going to trigger nitric oxide production in the first place? All right, so we got to talk about the triggers that we should definitely know for the USMLE. Okay, so certain triggers is going to be histamine, right? Just think about things that would want to vasodilate, right? Not vasoconstrict, but vasodilate. So what things we want to vasodilate? Well, we know histamine definitely causes vasodilation, right? Especially during allergies. We know that causes like edema, mucus production, and vasodilation, right? Warmth, swelling, things like that. So histamine is something that will definitely trigger vasodilation. Another one is serotonin. Then we have things like prostaglandins, right? Even cytokines, right? Inflammatory cytokines, as we know, can definitely lead to vasodilation, inflammation, edema, right? Water retention. Acetylcholine can definitely trigger vasodilation. Just sheer stress in general, right? Sheer stress on the blood vessel lining can lead to nitric oxide production. And then we have bradykinin that can definitely lead to vasodilation. And there's many more, right? So we also have alpha 2 agonists, so certain drugs that act on alpha 2 receptors on your blood vessels that will actually lead to vasodilation also, right? All right, so these are a lot of things that can lead to vasodilation. Okay, so let's say that any of these, right, can bind onto a receptor on our endothelial cell. And when it does, this will eventually, right, lead to an increase in calcium levels inside your endothelial cell. So then this increase in calcium levels will then go ahead and stimulate nitric oxide synthase, right? And the enzyme name gives it away, right? What does this enzyme help do? It helps make nitric oxide. Okay, so what this enzyme does is it helps convert L-arginine into nitric oxide. Okay, so now that we have nitric oxide, what nitric oxide is going to do is, right, it's gonna go nearby to the smooth muscle, right? So let's label this now. This is gonna be our smooth muscle cell. Okay, nitric oxide will diffuse freely to the smooth muscle cell right nearby, and then it's going to stimulate an enzyme called guanylate cyclase. And then once guanylate cyclase is stimulated, what does this enzyme do? It's going to convert GTP to cyclic GMP. All right. Now, cyclic GMP then will go ahead and lead to protein kinase G stimulation. Okay. So now we have protein kinase G in the picture. And this is very important because protein kinase G is actually going to help stimulate myosin light chain phosphatase. Okay. So this is going to be still inside the smooth muscle cell, right? So let's go ahead and extend this. All right. So protein kinase G will then go ahead and stimulate myosin light chain phosphatase. All right. Now, this enzyme is the opposite of myosin light chain kinase that we talked about earlier that led to vasoconstriction. So if it's the opposite, it's going to take the phosphate away from myosin light chain. So if it takes it away, myosin light chain can no longer bind to actin, which that means that it's going to lead to vasodilation, right? Because if myosin can't bind to actin, you can't cause that cross bridge formation and vasoconstriction. So myosin light chain phosphatase will strip that phosphate away from myosin light chain, leading to vasodilation, right? That's what nitric oxide does. Okay, so now that we know the biochemical pathway of vasoconstriction versus vasodilation, right, this will help us a lot when we now start talking about how nitrates work. Okay, so how do nitrates work? So nitrates right? They we already went through the pathway, right? It's going to be the same exact thing. So what nitrates do is when they enter your smooth muscle cell, so here, let's draw a massive smooth muscle cell again, right? Boom, that's our smooth muscle cell. Let's go and label that real quick. Smooth muscle cell. Perfect. Now you take nitrates, right? So nitrates are in the picture. And when you take nitrates, these nitrates, when they enter the smooth muscle cell, they actually get converted into nitric oxide. Okay. So that's good because now we already went through how nitric oxide leads to vasodilation. So basically, right, once nitric oxide is produced because of nitrates, and it's important to know that an important enzyme actually plays, or an enzyme plays a very critical role in this conversion from nitrates to nitric oxide. Okay, and that's going to be our mitochondrial aldehyde dehydrogenase enzyme, right? Mitochondrial, and then we'll just write that as an M, and then aldehyde dehydrogenase. Okay, so what happens, right? The nitrates, they enter into the smooth muscle cell. Then mitochondrial aldehyde dehydrogenase plays a really important role in converting those nitrates into nitric oxide. Now that we have nitric oxide, we should already know what will happen now, right? So nitric oxide will stimulate guanylate cyclase, right? Just like we talked about in the previous slide. So it'll stimulate guanylate cyclase. What does guanylate cyclase do? It converts GMP into, or sorry, it converts GTP, right? GTP into what? Cyclic GMP. What does cyclic GMP do? It leads to the activation of protein kinase G, right? So if you have a lot of protein kinase G now, what will that help in, right? So remember our enzyme that we talked about, myosin light chain phosphatase, okay? Protein kinase G will stimulate this enzyme. Then what will myosin light chain phosphatase do? It's going to strip away a phosphate from myosin light chain, right? So usually, because of myosin light chain kinase, myosin light chain has a phosphate attached to it. Myosin light chain phosphatase will go here, right, to myosin light chain and take that phosphate away. Now we remember that when myosin light chain kinase phosphorylated myosin light chain, that activated myosin light chain and it was able to bind to actin and lead to vasoconstriction. But because myosin light chain phosphatase now strips away that phosphate from myosin light chain, this myosin now can no longer bind to actin, which will lead to vasodilation, which is what nitrates do, right? And that's what nitric oxide does also. Okay, so that should make sense. And not only does myosin light chain phosphatase lead to vasodilation through its action of stripping away the phosphate from myosin light chain, but myosin light chain phosphatase also decreases intracellular calcium. Okay, intracellular calcium. And why is that important? Well, remember, right? Why is decreasing intracellular calcium important in terms of leading to vasodilation? Remember when we talked about the GQ pathway like 2 or 3 slides ago, we said certain things can trigger vasoconstriction, right? Like things that would stimulate the GQ pathway, right? Like what? Like adrenaline, noradrenaline, right? Endothelin, vasopressin, angiotensin 2, all those things bind to the smooth muscle, lead to the GQ pathway, lead to intracellular calcium that leads to an increase in intracellular calcium, right? And then that's going to lead to that calcium calmodulin complex we talked about, which will stimulate myosin light chain kinase, which will lead to phosphorylation of myosin light chain, which will lead to vasoconstriction, right? That's what we said. That was the whole biochemical pathway. But if you decrease the intracellular calcium, then you can no longer form many calcium calmodulin complexes, right? And if you can't form a calcium calmodulin complex, you cannot activate myosin light chain kinase, which means you cannot phosphorylate myosin light chain, which means you cannot lead to vasoconstriction, which means vasodilation. Okay, so that's why myosin light chain phosphatase is a really important enzyme when it comes to uh, the end product of when it comes to vasodilation. So hopefully that makes sense, right? So now we know, okay, we know how vasoconstriction occurs, how vasodilation occurs, and specifically how nitrates and nitric oxide lead to vasodilation, right? So now the next step when talking about nitrates is going to be to talk about the clinical use, like when would we use nitrates, right, as a drug? So there are basically four main clinical uses that we should be familiar with, right? Four main reasons of why we should use nitrates, right? So one reason would be acute coronary syndrome. So this would be consisting of, or this would consist of NSTEMI, right? STEMI and unstable angina. Okay. The other clinical use would be stable angina, and the other clinical use would be Prince metal angina. And the last clinical use that we should be familiar with is pulmonary edema. All right, so let's just go ahead and quickly talk about how nitrates help in each one, right? So let's start with acute coronary syndrome. Okay, so in acute coronary syndrome, you have a partial occlusion or a complete occlusion, right? So if it's an unstable angina or a NSTEMI, you have a partial occlusion that may or may not lead to myocardial necrosis, right? So if we quickly dive into this, right, we're going to talk about stable angina, unstable angina, and STEMI, right, in future videos, right? So this one is just going to be, or right now is just going to be a quick overview, right? So in unstable angina, right, if we take your blood vessels that supply your heart muscle, right, we're going to see something like this. So let's draw a different color. Let's draw this in yellow, right? We'll see something like this where it's partially occluded, right? Not completely, but partially occluded, um, actually close to 90%. Okay, so if we see this, right, this is partially occluded. However, no necrosis is usually seen, right? So you're not going to see a elevation in your troponin or anything like that, right? So no, you're not going to see any cardiac biomarkers that are elevated. So no troponin or and you're not going to see a STEMI, right? Because this isn't a STEMI, okay? This is um, unstable angina, right? So you're not going to see an ST elevation because it's not a transmural infarction, right? Infarction of your entire uh, myocardium, right? Your endocardium and myocardium. Okay, so again, your transmural would be like a STEMI, for example, where that's a full, complete occlusion of your coronary artery, right, which will lead to um, cell death of your entire chest wall, right, or your entire wall of your heart, the full thickness of your heart wall, right, which would be your endocardium, myocardium, and epicardium. Okay, but this is unstable angina. This is not a complete occlusion, it's a partial occlusion. So you don't see any necrosis yet. Okay, it's just subendocardial ischemia. Okay, and you may see things like chest pain at rest, right? So you may see chest pain at rest, and even worse with exertion. Okay, so you'll see that crushing chest pain may radiate to your arms or down your arms to your jaw, right? Those symptoms we've heard of a lot now, right? Relating to chest pain and all the radiation symptoms too, right? To your left arm, to your jaw, etc. But the main thing to know here is that if this is partially occluded like this, then imagine, right, downstream, if we were to draw muscle, right? Let's say this is myocardium, okay? Let's say this is our part of our myocardium, and it needs nutrients, right, in order to generate ATP and contract. Okay, so if this is partially occluded, though, if the coronary artery that's supplying this part of the myocardium is partially occluded, then that means less blood flow is reaching the myocardium. So it's already having a hard time, right, contracting. So if you were to, if it, so in this case, it's so occluded that even at rest, the myocardium is not able to get enough blood supply in order to do its job, which is why you get chest pain, right? Angina is all about having low supply, high demand, okay? That's all, that's the main thing to remember. That's what angina is, low supply, high demand, right? You're not getting enough blood supply, but the demand for the heart is always high, right? It has to pump blood to the entire body every time it beats. So if the demand is high, but you're not giving it enough nutrients, you're going to get that chest pain feeling. Okay. And so what nitrates do in this case, we already talked about the mechanism pretty deeply, right? We know how it leads to vasodilation. So in this case, what nitrates do is actually pretty cool. Its main way it works is it dilates your veins, right? So if you dilate your veins, so you go from a normal sized vein like this to something that's much bigger, right? Blood will pool in your veins, and that means less blood will make it back to your heart. Okay. So less blood, right, will make it back to your heart, which means eventually, right, the blood that makes it back to the right side of your heart will eventually go to the left side of your heart and eventually to the left ventricle. Okay. If less blood is making it to your left ventricle now, you just reduced the amount of pressure, tension, and stress in your left ventricular wall. Okay, so you reduce the tension, pressure, and overall wall stress in your left ventricular wall. Okay, specifically, right, you reduce the stress for your left ventricular myocardium. Okay, so because you reduce the stress, you reduce the pressure, you reduce the wall tension, your left ventricular myocardium now is going to be able to beat better, right? If the wall stress decreases, if the wall tension decreases, if the pressure that left ventricular wall, that left ventricular myocardium faces is decreased because of less blood flow entering it, right, entering the left ventricle, then that means that the demand, you just decreased the demand. And we said angina was a problem in having high demand and low supply. Well, now, because of dilating your veins due to nitrates, less blood makes it to your left ventricle. If less blood is entering your left ventricle, you decrease the preload, you decrease the left ventricular wall stress, tension, and pressure, which means you just reduced the demand. So now that should make sense. If you reduce the demand, then whatever supply that your left ventricular myocardium was getting will be good enough to the point where you won't have that chest pain anymore. Okay, you won't have that chest pain anymore, and that's why nitrates are good, or that's why it's a clinical, or unstable angina is a clinical use for nitrates. Same thing goes with NSTEMI and STEMI, right? So if you have an NSTEMI, right, that's also a partial occlusion, right? But this time it's occluded to the point where you get subendocardial necrosis. All right, so necrosis of your subendocardial layer. All right, and but again, this won't lead to ST elevation, right? So you're not going to see. So let's just write like this: you're not going to see an ST elevation, okay? Because ST elevation indicates transmural infarction. This is only infarction of your subendocardium, right? So you're only seeing subendocardial necrosis, not necrosis of the entire wall of the heart. So no ST elevation, but because there's necrosis, right? So again, we're talking about NSTEMI here. Because there's necrosis, you will see you will see an elevation in your troponin levels. Okay, but the same exact concept applies here, right? This very less blood flow is making it to your myocardium. So again, we can just talk it through now since we already went over the mechanism, right? If less blood flow is making to your myocardium, that's less supply, high demand. Okay, so then we have to figure out a way to reduce the demand. Well, the way we can reduce demand is keeping in mind Laplace's law, right? If you reduce the wall tension, the wall pressure, the wall stress, then you reduce its demand. Okay, you reduce the oxygen demand that the myocardium needs. So how do you reduce oxygen demand, myocardial oxygen demand? You reduce the wall stress, pressure, and tension. Well, if you dilate your veins by giving nitrates, you decrease the preload, you decrease the blood that makes it to your right side of your heart, which means eventually that decreased amount of blood is going to make it to the left side of your heart, right? So eventually, because you reduce preload, because you dilated your veins because of the introduction of nitrates, less blood makes it to your left ventricle. If less blood makes it to your left ventricle, you reduce the stretch, pressure, tension, right, of your left ventricle, which means you reduce the myocardial oxygen demand, which is really good, right? It's going to be good because that can help reduce some of that chest pain, okay? And reduce the demand of the left ventricle so that there's not a huge difference between the supply and demand, right? Because you're already getting low blood flow, so you don't want a high demand. You want to reduce that demand, okay? So hopefully that should make sense. And then again, that same concept, right, applies in a STEMI, except a STEMI would be a full occlusion, right? A complete occlusion. So if this is your blood vessel, it'd be a complete occlusion to the point where you have transmural infarction, right? So here you would see troponin elevation, ST elevation, right? You'd see all of that. And nitrates may be able to help a little bit, right, in terms of reducing myocardial oxygen demand, but keep in mind that in acute coronary syndrome, it's not just nitrates that are involved in the treatment, right? You also have to consider other things like anticoagulants or aspirin or um, morphine, oxygen, right? Things like that. And all of the um, we'll go over the treatment and everything about acute coronary syndrome in another separate video. Okay, but since we're just talking about nitrates, right, the main thing to keep in mind is the clinical use of nitrates is acute coronary syndrome, right, which includes unstable angina, NSTEMI, and STEMI. All right, now we can move on to the other clinical uses, right? So stable angina, and actually stable angina is the same exact concept as we talked about unstable angina, right? If you have a partial occlusion, right, of your blood vessels, but it's stable, right? It hasn't ruptured and it's not growing, right? So if you have your blood vessel here and you have a partial occlusion, it's the same concept to where if there's less blood flow going to your myocardium, right? So let's say this is your myocardium, then that means you have low supply and high demand, right? So it's a mismatch, so you may get some chest pain with exertion. Okay, so we're talking about stable angina here. Okay. So if you're getting low supply, high demand, again, it's the same exact thing, right? So if you give nitrates, you dilate your veins, you reduce preload, you reduce the amount of blood coming to your left ventricle. Therefore, you reduce the wall stress, tension, and pressure, and that will decrease myocardial oxygen demand. Okay, so that will lead to a low myocardial oxygen demand, which will then help reduce some of that chest pain and help um, and help the myocardium function better, right? Function with the low supply that it's getting. Okay, so it's the same concept that we talked about in unstable angina. All right, so another clinical use that we said was Prinzmetal's angina, right? So the Prinz metal angina. Now we'll talk about this in a separate video, right? There's a few causes for this, but the end result is that there's massive coronary spasm. Okay, so your coronary arteries spasm, and we can imagine why that can be a problem is because if you have a lot of coronary vasospasm, right, then that means sudden decrease of blood flow to the myocardium, so that can lead to sudden chest pain also. Okay. So again, that's a supply and demand problem, right? You suddenly decrease supply because of the massive vasoconstriction of the coronary arteries that supply your myocardium, right? But your myocardium still is in high demand, right? So there's still going to be high demand, but reduced supply. Okay, because your myocardium needs to be pumping blood to the whole body plus itself every time it beats. So of course the demand for the heart will be high, but because of the coronary spasm, you can reduce supply really quick. And if your supply suddenly collapses like that, why would nitrates help? Well, we know that nitrates lead to nitric oxide production in the smooth muscle. Then that nitric oxide can then stimulate guanylate cyclase, lead to the production of cyclic GMP, protein kinase G, stimulate myosin light chain phosphatase, leading to vasodilation, right? And that's what nitrates can do to your coronary arteries, okay? Especially specifically, right? Your epicardial arteries, okay? So it's going to help vasodilate. So let's say this is a blood vessel, right? Supplying your heart muscle, okay, or your epicardium, right? And then, um, so just as a refresher, remember we have our endocardium, then you have your myocardial layer, then your pericardium, right? So, but then we have the epicardium, okay, and just remember the epicardium is, so if we were to get more specific, right, the epicardium is the visceral layer of the pericardium. Okay, so that's the innermost layer touching the heart. Okay, so you have your epicardium, then your parietal pericardium, right? And then in between is going to be your pericardial sac, or sorry, your pericardial cavity, right? I should say, which has a little bit of fluid in it, right, to reduce friction. But if there's so what we're talking about here is an epicardial artery, right? So supplying the epicardium. And what happens is if this suddenly vasospasms, right, that's going to be sudden decrease of blood flow to your heart muscle and your epicardium, and nitrates can help dilate it, right? So if you vasodilate your arteries, supplying your epicardium or your myocardium, that can help um, increase supply, right? So that's that's why nitrates are can be used for Prinzmetal angina. Okay, so we talked about what clinical uses have we talked about? Acute coronary syndrome, which involved STEMI, unstable angina. We talked about stable angina, Prinzmetal angina, right? So then now we can talk about pulmonary edema, okay, which is our last clinical use that we should be familiar with. Okay, so let's talk about pulmonary edema. So why do nitrates help in pulmonary edema? So if we specifically talked about cardiogenic pulmonary edema, right? Pulmonary edema caused by left heart failure, then this should make more sense, okay? So let's say your left heart's failing, right? So what happens? Your left heart, so let's say just your left ventricle, and it's failing for whatever reason, right? You can have regurgitation, right? Mitral regurgitation, or you can have cardiomyopathy or a massive infarction, anything that leads to your left heart not being able to pump properly, or a volume overloaded state like regurgitation, like mitral regurgitation that we mentioned, or even mitral stenosis. Whatever the case, we have backup of blood, right? So let's say your left ventricle is failing. It's not able to pump blood forward to the aorta, so blood starts backing up. Where does it back up? To your left atrium, right? Then from your left atrium, where will blood back up? To your pulmonary veins. And then from your pulmonary veins, it's going to eventually make it down to your pulmonary capillaries, right? And that once it makes it down to your pulmonary capillaries, imagine all that blood constantly backing up, then the hydrostatic pressure in your pulmonary capillaries will increase a lot. And if it does increase a lot, fluid will leak out into your lung interstitium, right? So that will lead to pulmonary edema. So that should make sense, right? Fluid will leak out into your lung interstitium. Let's make that a little neater. So how will nitrates help then? We already know that nitrates dilate veins. So it's going to dilate your veins, right? Which will decrease preload, right? So if you dilate your veins because of the help of nitrates, right? So let's say these are huge veins that are returning blood to the heart, right? And if you dilate these veins, then you're going to cause venous pooling of blood. If blood pools in your veins, then less blood is making it back now to your heart. So you're decreasing preload, right? Because this less amount of blood that's making it back to your right side of your heart will eventually make it to your left ventricle, right? So then that means your left ventricular stress, right? Your left ventricular end diastolic pressure and the tension in your left ventricular wall will all decrease. And that's good because if the pressure and stress, right, and the tension of your left ventricle decreases, then that means the left atrial pressure will then decrease. And if your left atrial pressure decreases, the pressure in your pulmonary venous system will decrease, and eventually that will lead to the decrease of the pressure in your pulmonary capillaries, which will then decrease the hydrostatic pressure, which will mean less fluid leakage into your lung interstitium. So then you're giving your lymphatics a chance to reabsorb that pulmonary edema, right? Not because you decrease the hydrostatic pressure, you're giving your lymphatic system in your lungs a chance to reabsorb that fluid and the capillaries to reabsorb that fluid. So that's how nitrates can help in acute pulmonary edema, specifically cardiogenic, okay, caused by left heart failure. All right, so those are all the clinical uses. Now we can move on to the last section of this video, which is going to be adverse effects. All right, so there's actually many adverse effects. All right, so what we're just gonna go one by one, okay, and talk about the mechanism for each adverse effect real quick. All right, so let's start with the first one, okay, which is gonna be headache. Right, so the first adverse effect is gonna be headache. Okay, so let's real quick, how does this happen, right? Why does this make sense? So we know nitric oxide now, right? We know nitrates, right, lead to the production of nitric oxide. And what does nitric oxide do? Vasodilate, right? We know that really well now. It leads to vasodilation. Nitric oxide leads to vasodilation. So if you have blood vessels near your meninges, okay, right, near your meninges and these blood vessels vasodilate, right, when you take these nitrates, then your meninges will sense that, right? Because we know your meninges are very pain sensitive. So they have nerves that will detect pain. And if you have vasodilation, right, let's say there's many blood vessels near your meninges. Um, so let's just draw a lot of blood vessels, right? And all of these blood vessels are going to be near your meninges, right? And if these all vasodilate, then if your meninges are very pain sensitive, then you're going to have a lot of nerves that relay this pain, right? This information, right, to your central nervous system, and then you'll perceive that as pain, right? Or headache in this case. Okay, so that should make sense, right? You vasodilate your blood vessels near your meningeal tissue. Your meningeal tissue will pick that up as pain because your meninges are very pain sensitive, okay? And then that's gonna have that headache sensation. Okay, so hopefully that makes pretty sense because your cerebral arteries are very sensitive to nitric oxide. Because if you dilate your arteries or if you dilate your cerebral arteries, then that can definitely stretch certain structures in your meninges. And if that stretches certain structures in your meninges, then that will definitely lead to pain, or that will definitely lead to a big headache, right? So the next adverse effect from nitrates is going to be flushing. Same concept here, right? Your blood vessels that supply your skin or your cutaneous blood vessels will vasodilate because that's what nitric oxide does, right? That's what nitrates do. It leads to the production of nitric oxide. And nitric oxide, as we well know now, dilates your blood vessels. So if you vasodilate the blood vessels supplying your skin, you're going to have more blood flow going to your skin, which is going to lead to warmth and flushing. Okay, so that should also make pretty good sense. All right, so what's another adverse effect? It's going to be hypotension, right, and dizziness. Now, why does this happen? Well, we said nitric oxide, right, or nitrates lead to the production of nitric oxide, and then that vasodilates. In this case, nitrates are really good. Nitrates are really good at dilating your veins. So remember, we went over this a few times where if you dilate your veins, you decrease preload, which means you decrease the amount of blood coming to your heart, which eventually, right, that means that you decrease the amount of blood coming to the left side of your heart, right? So initially you decrease blood flow to the right side, but eventually to the left side, right? So you decrease preload. If you're decreasing the amount of blood that's making it to your left ventricle, then your left ventricle is pumping out less blood, which means you can drop your blood pressure, right? So that should make pretty good sense. And if you're pumping out less blood, then that means you're pumping less blood to the brain, which can lead to dizziness. So that's why we see hypotension and dizziness, right? Low blood pressure and dizziness. Okay, because again, you're pumping out less blood, which means your cerebral perfusion can fall, which can lead to lightheadedness or syncope and dizziness, right? So that's definitely an adverse effect to keep in mind of nitrates. And especially at higher doses of nitrates, you can lead to arterial dilation too, which will then reduce your systemic vascular resistance, which will further reduce blood pressure, right? Because we know that blood pressure is equal to total peripheral resistance times cardiac output. So total peripheral resistance can drop a lot if you give high doses of nitrates, because that leads to arterial dilation, right? And if you decrease your total peripheral resistance, you decrease your blood pressure. Okay. So that's another reason why hypotension can occur with nitrates. So that should make sense too, right? Another adverse effect that's definitely important to keep in mind is reflex tachycardia. All right. So how does this work? Well, we know that this will reduce nitrates can reduce blood pressure, right? Because it's going to decrease the amount of blood making it to the left side of your heart, which means your left ventricle will pump out less blood, which means low blood pressure. Now, low blood pressure can be detected by your brainstem. Okay, so low blood pressure will stimulate your brainstem, and your brainstem can then activate the sympathetic fibers, right? And those sympathetic fibers will then go to your sympathetic fibers, right, that come out of the T1 to T12 portion of the spinal cord, right, can go and supply your heart, right? So if you have increase in your sympathetic nervous system because your blood pressure falls, then that's increase in your sympathetic tone will lead to a higher heart rate and higher contractility. Okay. So again, let's just go through this mechanism once more so it's more clear. Because nitrates reduce blood pressure, that's going to stimulate your brainstem and tell your brainstem, hey, we're not having that much perfusion. So your brainstem will activate the sympathetic fibers that come out of the T1 to T12 portion of your spinal cord. Those sympathetic fibers will go to many places. One of those places will be your heart. It's going to go to the beta adrenergic receptors of your heart, which will increase heart rate, right? Because adrenaline will act on your SA node, and it's going to increase your contractility because adrenaline can bind to your myocardium and increase how hard it contracts, right? So you're going to increase heart rate, you're going to increase contractility. But remember, the reason for giving nitrates was to reduce myocardial oxygen demand. And increasing the heart rate and increasing contractility is doing the opposite. So the way to control this would be not only would you give nitrates, but you could also, right, pair that with beta blockers. Why? Because beta blockers block the beta adrenergic receptors on your heart. So even though the sympathetic nervous system does fire, it won't be able to bind and effectively increase your heart rate and contractility because you have beta blockers that are blocking the adrenergic receptors on the heart. Okay, so that's reflex tachycardia. Another adverse effect, right, will be methemoglobinemia, right? Methemoglobin anemia. Okay, methemoglobinemia. And why does this occur, right? So the reason why this occurs is because when you give nitrates, okay, nitrates can oxidize the iron in your hemoglobin. Okay, so again, the introduction of nitrates can oxidize the iron in your hemoglobin. And what does oxidation mean? You're losing an electron, right? So you're basically becoming more positive. So you can go from Fe2 plus in your hemoglobin to, right, Fe3 plus. And Fe3 plus can't, what's Fe3 plus? That's methemoglobin, right? Hemoglobin with oxidized iron is methemoglobin, and that cannot bind, right? You cannot bind oxygen anymore effectively. Obviously, that would be bad because that can lead to hypoxia. Okay. And so you would see the normal signs of methemoglobinemia that we've covered before, which would be cyanosis, chocolate-colored blood, and so on, right? And then the what would be the treatment if you guys remember would be IV methylene blue, okay? Because that can reduce the oxidized iron back into Fe2 plus and then make normal hemoglobin, not methemoglobin. So that's another adverse effect that we should be familiar with. Another adverse effect, right, would be something called Monday disease. And the mechanism for this is actually pretty cool. So let's go ahead and see how this works. So the way this disease actually works is pretty cool because what happened was, back then in the like 1800s, right? This was a while ago. I'm just saying like how this disease was named the Monday disease, right? What was the history behind it? Is that these workers, these factory workers in the 1800s were constantly exposed to nitroglycerin vapors, all right? And if you're constantly exposed to nitroglycerin vapors, what happened to these workers was that on Monday morning, right? So on Monday morning, these factory workers would have all the adverse effects that we talked about, right? They would have headache, they would have the like hypotension, dizziness, syncope, right? Hypotension, dizziness, even syncope. They would have like palpitations, right? Flushing, all these symptoms that now we know why this happened, right? Due to the exposure of nitrates. And because they would have all of these symptoms Monday morning, and then what happened was as the weeks went on, or as the week, sorry, as the week went on, right? By Friday, let's say, what happens when you are constantly exposed to nitrates is that remember the enzyme we talked about, right? So remember when we gave nitrates, those nitrates went into your smooth muscle cell and converted to nitric oxide, and we said a major enzyme that helps this process occur is mitochondrial aldehyde dehydrogenase. Dehydrogenase. So remember we mentioned this enzyme, right? So what happens is that as you're constantly exposed to nitrates, this enzyme, the mitochondrial aldehyde dehydrogenase enzyme starts becoming less effective. Okay, so you start decreasing the effectiveness of this enzyme as you constantly are exposed to nitrates over time. So that's what happened to these factory workers during the week as they were constantly exposed to these high amounts of nitroglycerin vapors. They they started to get resistant to the nitrates. So then you started to produce less and less nitric oxide, even though you were exposed to a lot of nitrates, right? A lot of those nitroglycerin vapors, which means you had less and less effects of that vasodilation. So these symptoms went down over the week, even though you were exposed to the same amount of nitrates. But then they went, right? But then the weekend came, right? And they went home and they didn't have work and everything got more desensitized, or sorry, got more sensitized, right? During the week, they got more desensitized to the nitrates. Over the weekend, since they weren't exposed to those vapors anymore, their body got more sensitized. And once they came back Monday morning, they had these symptoms all over again. All right, because now you're making more nitric oxide, you're more responsive to the nitrates because you got sensitized over the weekend due to not being exposed to the nitroglycerin vapors, right, at the factory that these workers were working at. So that's why it's called the Monday disease. And I just thought the mechanism of action and the history of that was kind of cool. Okay, so that's Monday disease, and then now let's move on to the next adverse effect. So the next adverse effect, or in this case, we talked about all the adverse effects. Let's talk about the contraindications. Okay, so the next the first contraindication that we need to be familiar with, right, is going to be right ventricular infarction. Okay, and so let's label this slide as going to be indications. Okay, so when should you not use nitrates? Okay, that's basically what contraindications mean, right? In what scenario should you not use nitrates? So the first scenario, the first contraindication would be right ventricular infarction. Okay, so right ventricular infarction. And why is this? Well, because if we remember, right, the right ventricle relies on preload very heavily. Okay. It relies on the preload. So if we know that, right, the right ventricle relies heavily on preload. So that's actually really important. Let's write that down. The right ventricle heavily, okay, relies on preload. Okay, so that it can pump that blood to the lungs, get that blood oxygenated, so your left ventricle can then take that oxygenated blood and pump it to the body. But what do nitrates do? They reduce preload by a good amount. How? Because they dilate your veins. So if you have right ventricular infarction, right? Let's say you had a a severe blockage in your right coronary artery, right? Or something like that, that would that basically killed off a good chunk of your myocardium of your right ventricle. And now that portion of the right ventricle cannot really contract anymore. Okay, so you lost a lot of contractility capability, right, in your right ventricle, which means that you're not really pumping enough blood out anymore to the lungs. On top of that, if you give nitrates, you reduce the preload, you reduce the amount of blood coming to the right side of your heart. So now, right, so let's say we drew the heart, right, and we focus on the right side, right atrium, right ventricle, and we said that, right, let's say this is your right coronary artery, and you had a massive occlusion, and let's say you infarcted, right? All of this, okay, all of this was infarcted, right? All of this is now dead myocardial tissue. So now you can barely pump blood, right? Your right ventricle can barely pump blood. That's the main thing to keep in mind. In a right ventricular infarction, your right ventricle can barely pump blood already. On top of that, if you're not allowing blood to come to the right ventricle, you're going to make things way, way worse. Okay, so that's the same thing as saying if you decrease preload to a right ventricle that's already struggling to pump blood to the lungs, then you're going to make things 100 times worse. So it's a very big contraindication to keep in mind when talking about nitrates. A huge contraindication is right ventricular infarction. Okay, because if you decrease preload, you're not pumping much blood to the lungs anymore at all, which means you're not returning any oxygenated blood to the left ventricle. So you're reducing left ventricular filling and the amount of oxygenated blood that's coming to the left ventricle, which means you're decreasing systemic perfusion a lot. Okay, because see, if you're not pumping enough blood to the lungs, right? Like not enough blood at all, you're not much blood is going to come to the to the left ventricle, right? Eventually, and that means your left ventricle is not going to be pumping much blood out to the systemic circulation. Okay, so you're going to get decreased perfusion to your vital organs, including your own heart muscle, right? So hopefully that should make sense. So if you have like an inferior MI, right, then that's going to definitely knock out a huge portion of your right ventricle, which would mean that decreasing preload is not something you would want to do. Another contraindication to nitrates would be hypertrophic obstructive cardiomyopathy. All right, so let's write that down. Another contraindication would be hypertrophic obstructive cardiomyopathy. All right, so we'll talk about this in a separate video, right? But in just real quick, right? A nice overview would be like, what is this? Okay, so you're gonna have your right atrium, right ventricle, left ventricle. And in this condition, right, you have severe obstruction on the left side of your heart. So, and it's an irregular hypertrophy of your septum. Okay, so imagine something very irregular, right? And it's bulged out like this. And if you imagine, like right now, right, if you imagine um that the aortic valve is right here, right? And the left ventricle has to pump past this obstruction, right, of the septum through your aortic valve. So your left ventricle is going to have an insanely hard time pumping blood through this big to this through this obstruction, right, that we see here with the myocardium that's hypertrophied irregularly. Okay. And so if your left ventricle cavity is already small, right, because of this massive hypertrophy of the septum, and it's working insanely hard to pump past this obstruction right here, right, through the aortic valve and to the aorta. On top of that, you say, hey, I'm going to decrease the amount of blood you have going into you, right? So now the left ventricular cavity, as we can see, is already small, and it's having a very hard time pumping past the obstruction that the irregularly hypertrophied septum is causing. On top of that, you massively decrease preload, right? So now you're barely pumping any blood out to the systemic circulation, okay, which can lead to syncope, dizziness, low blood pressure, right? Things like that. So hopefully that makes sense too, right? Why hypertrophic obstructive cardiomyopathy is a contraindication for nitrates. And the last contraindication, though, that we should definitely talk about and keep in mind is concurrent phosphodiesterase 5 inhibitor use. Okay, so PDE5 inhibitor use. Now, what are PDE5 inhibitors, right? What are some examples? So PDE5 inhibitors are something that we were already familiar with, right? So things like sildenafil. So let's go and write these down real quick. Sildenafil, right? And then we have Viagra, which is also sildenafil, right? So something to differentiate when talking about pharmacology is like this is the active ingredient, right? So the brand name, though, right, would be Viagra, right, as an example. And then you have tadalafil, right? So tadalafil, and that's the active ingredient in, and then the brand name, right, would be something like Cialis, right? Because there's many brand names that have tadalafil, or there's many brand names that contain sildenafil, right? But we're just going through one brand name example for each active ingredient. So Cialis would be an example of a brand name for tadalafil, right? For the active ingredient, tadalafil. And then we have things like avanafil or vardanafil, right? But like it's mainly these are just examples of PDE5 inhibitors. The main thing to understand here, though, is why this is a contraindication. So if someone is using sildenafil or tadalafil, right, or Viagra or Cialis, that is a contraindication because we have to first understand what PDE5 does, right? So remember the cyclic GMP pathway that we talked about, right? The guanylate cyclase pathway that always comes up, okay, in this case too. Remember, when nitric oxide goes into your smooth muscle, what does it do? It activates guanylate cyclase. Okay. Once guanylate cyclase is activated, what does activated guanylate cyclase do? It converts GTP into cyclic GMP. What does cyclic GMP do? It activates protein kinase G. What does protein kinase G do? It stimulates and activates myosin light chain phosphatase, which then leads to, right, vasodilation as we're familiar with. Okay. Where does phosphodiesterase 5 come into play here? So phosphodiesterase 5, right, degrades cyclic GMP. Okay, so that's very important. Phosphodiesterase 5 comes over, right, to cyclic GMP and degrades it, which then means you're going to have less protein kinase G and less activation of myosin light chain phosphatase, which means less vasodilation and more vasoconstriction. So you can imagine why someone would be taking phosphodiesterase inhibitors, right? For example, why would someone be taking Viagra, right? If they have erectile dysfunction, right? That could help that could help with that, right? Because it can help dilate the vessels going into your, if it's a male, right? You can help dilate your vessels going to your genitals, which can help with erectile dysfunction. But if someone's taking Viagra for erectile dysfunction, let's say, on top of that, they start taking nitrates. What do nitrates do, right? What do nitrates do? So first, let's write this down. So if you're taking Viagra, what is that doing? You're inhibiting PDE5, which means you're which means you're not going to break down cyclic GMP. So the concentration of cyclic GMP is going to increase. You're going to have more protein kinase G, more myosin light chain phosphatase activation, more vasodilation, which can be helpful in someone with erectile dysfunction. But on top of that, if you combine nitrates, that will be very dangerous because nitrates do what? It increases more cyclic GMP production, which means you're going to have even more protein kinase G activation, more myosin light chain phosphatase activity, more vasodilation. More vasodilation is not good because what does that do? That significantly decreases systemic vascular resistance, right? What formula are we familiar with from cardiology, right? Or from our previous videos? Is blood pressure is equal to total peripheral resistance times cardiac output. If your systemic vascular resistance is dropping heavily now because you just combine nitrates and PDE5 inhibitor like Viagra, right, or sildenafil or tadalafil, right, Cialis, any of that, you decrease total peripheral resistance significantly, so you decrease blood pressure significantly. So that's why it's really bad because that can lead to syncope, and dizziness, hypotension, and so forth. All right, so that's basically it. I mean, those are the main contraindications: right ventricular infarction, hypertrophic cardiomyopathy, and phosphodiesterase 5 inhibitor use. Like what? Like sildenafil or tadalafil or many others. All right, so that's basically it, right? That was a long video, but um, actually, before we end it, right, let's just talk about what nitrates, what are the types of nitrates that we should be familiar with, right? So it's going to be nitroglycerin, right? All of these do the same thing. It eventually leads to nitric oxide production, right? Isosorbide mononitrate and isosorbide dinitrate. Okay, so let's just quickly talk about the differences for each. So nitroglycerin, right, is usually used for acute cases. Okay, so like it's built for speed and control, right? It's not something that's meant to be chronic. It's not a chronic nitrate that you usually take, right? It's meant for acute situations. Okay, so like if the symptoms are happening right now, or you need to do something right now, or clear the chest pain right now, right? Then that would be when nitroglycerin is used because it has a very short half-life. Okay, so let's write this down. It has a very short half-life and it acts pretty quickly too. Okay, so it has a short half-life and acts quickly. So it's going to get absorbed quick, right? Act very quickly, and then it's going to get worn off quickly. All right, so that's why it's not a chronic nitrate, it's an acute nitrate. What happens is it gets rapidly metabolized by the liver, which is why you don't, the route of administration is most commonly sublingually, right? Or IV. Not, or not, you don't take it um, orally and swallow it because if you swallow it, then it's going to get destroyed by your liver before it makes it out to your systemic circulation. Okay, but once it's absorbed, right, it generates nitric oxide very quickly in your smooth muscle, causes rapid dilation of your veins, and then it wears off quickly also. Okay, so that's nitroglycerin. It's for acute cases like what? Like acute angina, right? Or acute coronary syndrome or acute pulmonary edema, right? Things like that. Isosorbide dinitrate and mononitrate are more related to chronic use, all right? Um, Something important to know is isosorbide dinitrate, when you take it, right, it goes to your liver. and actually gets metabolized into the active form, which is isosorbide mononitrate. Okay, so isosorbide mononitrate is the active nitrate. Okay, that's one thing important to know. But like, would you use isosorbide dinitrate in cases like in chronic cases, right? Like chronic angina, for example. But it's not an acute drug like nitroglycerin. Okay, so isosorbide mononitrate and dinitrate are more for the chronic cases, while nitroglycerin is the more acute for acute situations. Isosorbide dinitrate and hydralazine can be used in substitution for ACE inhibitors and in certain patients that have heart failure, but they don't tolerate ACE inhibitors. Okay, so remember the side effects of ACE inhibitors, right? Can be, for example, angioedema, right, is a dangerous side effect. Severe cough and bronchoconstriction, pulmonary issues can be a side effect, right, along with hyperkalemia and so forth, right? So if there's certain populations that have heart failure and that cannot tolerate ACE inhibitors, we need a way, we need another substitution for a drug, right, that can do what ACE inhibitors do hemodynamically, okay, but that don't cause these side effects in these populations, right? So ACE inhibitors, right, what do? They decrease angiotensin 2 and decrease aldosterone, right? And so what that does is angiotensin 2, right? If you decrease that, what does angiotensin 2 normally do? It vasoconstricts hard, right? So if you decrease this, you decrease afterload, making it easier for your left ventricle to pump blood forward. If you decrease aldosterone, you decrease sodium and water retention, means you decrease preload, which means you decrease the left ventricular wall tension, stress, and pressure, which means you decrease myocardial oxygen demand, which is also good for heart failure patients. So that means we just need another alternative that can decrease preload and decrease afterload, right, to have the similar effects of ACE inhibitors. And that's where isosorbide dinitrate and hydralazine come in. Isosorbide dinitrate is a nitrate, and that what does that do? It dilates your veins, which decreases preload, right? Which we're familiar with. Hydralazine it dilates your arteries, your arterioles, right? Which will decrease your afterload. Okay, so that's why isosorbide dinitrate and hydralazine can be a substitution for a subset for a population, right, that cannot tolerate ACE inhibitors and that that have heart failure. Okay, so that's another use of isosorbide dinitrate. And then isosorbide mononitrate is more, it just has a longer half-life, right? Longer half-life than nitroglycerin. It's more stable, and it's more used for something chronic, again, like chronic stable angina, right? So those are the main differences to know between nitroglycerin, isosorbide dinitrate, and isosorbide mononitrate, okay? So those are the nitrates. And that concludes this video for nitrates. I know it was a really long video. I hope it wasn't too confusing. I hope it made sense. Thank you guys for watching and see you guys in my future videos.